So, deep, deep, deep. Don't go here. Careful, because you might blind the patient, so I don't like to use needles here. Kent is very careful about putting it on bone with a BD2. Don't go under the skin over here with needle because you're going to hurt the patient. One up, one over, superficial or deep, cannula, and there's only one area left that we have to worry about, the face, and that's the piriform region. And that's the most dangerous region, and we all inject there. So here's the bottom line on the piriform. That artery that's going back and forth like this crosses over into the piriform area in Caucasians 4% of the time. 1 in every 25 Caucasians, you'll pick up a pulse over here, or sometimes it's there and you don't pick up the pulse. It happens 17% of the time in Asians. That's 1 in every 5 Asians. Why does it happen 1 in every 5 Asians? Because of the fact that they have no bone structure over there, so during embryology, the artery can wander. And in a Caucasian, when we start to develop the bone, the artery is too lazy to climb up over the hill. So that's why we're seeing more cases of issues that are occurring in the Asian population than Caucasian. So you know that the artery can be down there, but we heard Ken say we want to inject there because we recede as we age, and this is a great place to build forward, to narrow the nose, to prop up the nose, and to get rid of that triangle that's the depressed triangle. So we'd love to inject there. So you must inject where the artery is not. Okay, so you have to inject where the artery isn't. And there's only one place that the artery is, in the subcutaneous tissue. It is not on bone, because when we do rhinoplasties over here, we look for the bone and we chisel along the bone. It's not in the skin, but it's somewhere in between. So my injection technique is either to put product into dermis, feeling the resistance again. I do not go under dermis over here with a needle. You can do it like Kent did with a cannula coming up from the side, but I don't use the needle over there. And if I'm using a needle, which I'll use on him to show you the technique, I'm angled down and aiming towards the opposite commissure. Got it? By aiming away from the artery, which is the continuation of the angular artery here, not in all cases, but in most cases, I'm staying away from trouble and I'm putting it on bone. I might skewer the artery, so I'm prepared with the pad, but I won't be in it. So deep, deep, deep. Careful here because of blindness. Careful here because of pain. 1 up, 1 over. Superficial or deep. Cannula. In skin or on bone. That's the entire face for injections, guys, except for lips. We'll talk about lips and chin afterwards when we get there to the next patient. But that's injection anatomy. So now we're going to inject. Can I have a cleanser? And let's get this thing rolling. I'm going to inject the mid part of his face. When I inject the mid part of the face, and I can ask Kent what his preference is, I like to inject lateral face before I inject medial face. Medial face, tiger country. Lateral face, lambs. That's why we're not seeing as many complications here as they're seeing on the other side of the world, because typical Asian, that's a little too wet. The typical Asian face, okay? The typical Asian face is centrally retrusive. Flat glabella, low radix, receded piriforms, right? Thank you. Receded piriforms, retrognathia, low dorsum. All their injections are centered in the danger area. This is the watershed area between internal and external carotid system. So all their injections are here. We age out here. Look at me, I'm deflated out on my cheeks over here. So this is where we want to inject. We're dancing with lambs, they're dancing with tigers. That's why they're getting into trouble. Not because they're bad injectors, it's because they're constantly going into areas that are high risk. Okay, so if this is a high risk area or a higher risk area, I want it to be one of the last areas to inject, because if I can figure a way not to go there, I'd be very happy. Okay, so I'm going to inject laterally first. Can I have the marking pencil, please? I'm going to show you on him how I would inject him. Any color. Anything that would just show purple on him. Yeah.
No, he doesn't want purple. Give him the white.
Yeah, white is fine. Thank you. Yeah, this is a nice white pencil. Lateral iris is my boundary. This is an area that I want to fill. This is the lateral iris. Let's say I need 2 injection points. He doesn't need much. I'll inject the higher one first, the lower one second, and I stay lateral to the line, because if I'm lucky, I can milk some of the product over and not have to do anything on that danger zone over there. I'm going to use the product that he gave me, which is Define.
Fine.
It's pure.
Straight up with a Terumo needle, so it's 30...
I know, your butt must be hurting.
28, 29 gauge.
If you want water or something, just let me know.
30.
I stabilize my hand. I'm going in vertical. That's the shortest distance to bone. I'm going to pinch the skin up at the same time that I go into the skin, and I'm sitting on bone right now. I'm going to inject. I'm going to keep my hands away just to show you. I'm going to inject very slowly, putting in a little bit of product. I'm going to release off the bone and lift. And this is what we were talking about before, is doing the lift and allowing the product to run up to the skin. Okay? And I'm going to use a bolus of no more than 0.15. I'm going to remove my needle. You'll notice that there's very little bleeding that occurs, and that's because by doing that little maneuver of releasing off the bone and lifting slightly, what happens is you tamponade. You let the skin ride back down over your little injection point, and it tamponades the deeper vessels. It tamponades the blood from coming up. Okay? Wasn't too painful? And I'm going to do the same thing over here. When I get down to this area over here, I'll just clean him a little bit again. Okay? He's a little flat over here. I'm sitting at the angle of the bone. I can put the product on bone or superficially. I'm down on bone again. Small little injection. Release and lift. Okay? I can't even see my plunger yet, so I haven't used that much product. Good. We're going to clean him up here for a second because he doesn't need much. He's being a very good demo patient. We're going to sit him up. We're going to have him look into the mirror. I'm going to try to angle his head again. Okay. I'm not going to take full credit. I'm not going to take full credit for anything to do with the nasolabial fold. Okay? I've used the total here of 0.2. I'm actually at 0.8, so I put in 2 little boluses of 0.1. But take a look at the fact that we've flattened out where this area over here, where you see the light reflex, that's too medial. We've now curved this area over here where you don't see the light reflex. Okay? If he's having any effect on a nasolabial fold on this side, it can't be from my product, guys. Come on, I just can't believe that I'm pulling that hard, that it was better when we started, but I can't believe that any improvement is from that. I have a feeling that that chair effect that we talked about, I'm softening, I'm doing what my colleague over there said, is I'm resetting his face to the way it was years ago, and there's muscle memory that's sort of taking over and saying, yeah, that's the way I remember it being. Okay? I haven't used a lot of product. He doesn't need much product. He's too solid. I was expecting him to deflate more since I've seen him. But I'm going to show you now, even as we bend him forward, or I can tilt him back up over here, okay? You can see the hollowing that he has on this side, that we've now started to fill in that area where we had the crease. He's looking good. You check him from on top. And now we have to optimize his cheek. He's got a really good-looking cheek now. He had one before. But now we have to knock the ball out of the park so that he is a raving fan. And how do we do that? We're going to mark him. So remember the marking that we did. I'm going to take a pencil over here, doing a lot of talking, but we're going to get through this. Okay? I'm going to mark out the lateral iris, the vertical line that's coming down towards this. Remember, on a female it would be here, on a male it would be here. Okay? Bottom of the tragus coming across over here. Right? Bottom of the tragus coming across over here. Here's my vertical line. So take a look at an ideal cheek on this guy right over here on Ryan, okay? You see how it's more this way than it is this way? It's wider spaced. If we take a look at it, he's doing pretty good. But now that I've got this marked, do you see this? Now that I have this marked, I'm only looking at one thing on his face. It's drawing my attention to that simple circle. I don't look at anything else on his face now because this is going to be his ideal cheek mount for his facial morphology, for the height, for the width, for where his ear is, for his nose is, where everything is. And I see when I look at this neck now, I'm getting the impression that there's some flatness right over here, and you can see it when I turn him.
Correct.
Do you see that?
Yeah.
We got to correct that. But that is sitting just about at the level. Let me have the same product again, please. Now, I can do that with a cannula. I can do it with a needle. We'll do it with a needle on this side, maybe a cannula on the other side. Whatever your preference is, you're going to feel a small little stick. And what I'll do is I'll just fire it in again. We're going to lift it up, and we're going to go ahead and inject. How you doing? I'm on bone right now. Okay, I'm putting in a small amount. I'm going to put in my 0.1 of product again. It's a very nice moldable product, this product. And we're going to release. Again, no bleeding. And look how that thing has popped up now. Do you see that he has a little curve there now? Maybe a little bit too much. We can pat it down. Okay? And now what we have to do, let me take it one more time. There's a small little dent over here. Can you change that needle for me, please? Thank you. Put another red one on if you don't mind. Anytime I touch the bone, I usually ask my my nurse to go ahead and to change.
What do you want?
Same thing. Same product. I just want
a needle?
Yeah, same type of needle, but you can just give me a fresh one, that's all.
Oh, okay.
Okay? I think I have a whole bunch of my
I got 'em.
in my little tackle box there. I love those needles. They're very good. They're 29 outside and 27 ultra thin wall, UTWs they're called. You maybe see it on the big thing. He has a little teeny thing here. And then we're going to find the apex of his cheek, and then we're going to see what we did. And I'm telling you, I knew he wasn't going to be much to begin with, but we'll have used on him.
Prime the pump.
Prime the pump. Thank you. Small little injection again. Flick the skin back into the needle. Small little amount of injection, nice and slow and deliberate. There we go. He seems to be too comfortable. There we go. Good. That's more like it. Let me clean this up, please, and then let me have the marking pencil one last time. You got your calipers. We're going to measure his calipers because that's what I was asked to do on the male. We're going to use the calipers to see what would his ideal cheek be for this side with small amounts of product. You know, I want to do this whole face maybe with 2 cc's of product. That's it. Okay? Here we go. Okay. Cleanser, please. Here's your cap for the other one. Thank you. I'm going to draw a line from the bottom of the nose, the alar base over here, to the bottom of the tragus. So it's a line that comes across like this. I'm going to ask for the calipers.
Yeah.
Okay. I'm going to ask for the calipers. We're going to measure the inside of his intercanthal line over here, which is 1. We're going to go with 1.618 across over here from the inner canthus to see where it crosses. It crosses right here. Okay? Very good. If it was a female, we would be up around here somewhere. We'd be up and out, but this is down and in. Let me have a little bit of the product again, please. And we're going to create a little light reflex over here. Okay? I'll go just medial to my mark so I don't go ahead and tattoo him with anything. There we go. And I'm going to put in a small amount of product where I think the apex should be on a male. I've now come to 1/2 cc of product. Exactly. Just that. You see the little light bouncing off him right there now?
Yeah.
I see it. I don't know if you guys can see it. He didn't need much. Okay? Because he still has a good result from last time. We're going to straighten out his head. We're going to get him to look forward over here. And we have a... Always get him to smile.
Yeah, it shows well on these monitors, but this one's a little dark, so it doesn't show it as well. But the light reflex is nice here.
Okay. Yeah, but that was, again, the fact because he didn't have much of one on this side, too. But look at that eyebrow that's still sitting up on that side. The eyebrow's been elevated. The nasolabial fold has been improved. But it started as a better area to begin with.
Right.
But I certainly like his look on this side. Again, I'm having trouble. There it is. Come on.
See, the advantage is he had a fold on the right side, but on the left side he has a crease.
Right.
So the crease is more difficult.
So I'm going to do one more thing. I'm going to do one more thing because he's got such good structure. I'm going to do one more thing, then I'll finish off the other side of his face. But I want to go ahead and see if I can optimize his nose a little bit. So we'll talk a little bit about nose anatomy. Anybody here doing nose injections? Good for you. It's where a little bit of product goes a long way. There's no question that a small amount of product. So if I was to try to figure out what the ideal thing would be for his nose over here, don't mind me going ahead and injecting. He doesn't care at all. He's having too good a time. Okay. Look into the camera again. Just straight ahead. Okay. I take the tarsal fold. I come across where the tarsal fold is over here. And that's where nose should normally take off on a male. He's a little bit steep over there. You can see that. Okay. So what I'm going to try to do is I'm going to try to do this. Give him a little bit more height. What are you going to give me, Kent?
Mini refine.
Mini refine. Okay, so what we're talking about over here is to stay midline. If you want to stay as safe as possible on the nose, you must stay midline because the dorsal nasal arteries are paired and they're just off the midline laterally. That's how the Asians were getting into trouble, is they were firing a cannula all the way up like this, and they happened to be a little off midline. They were catching that lateral nasal artery, and they were cannulating it, and it was going right into the supratrochlear and back into the eye. So you don't want to do that. I suggest vertical approach with the needle, alternative sideways. If you stay on periosteum in the midline, if you stay on cartilage in the midline, that is the safest of the areas, because there's a small plane over there. The fibrovascular layer of the nose, it goes skin, subcutaneous tissue, muscles, then a fibrovascular layer, then a gap, and then the periosteum and perichondrium. It's like 5 layers. So we're going to target that. So I'm going to come straight down over here, Ryan. You're going to be great on this. Okay, you guys can see. I'm going to go ahead and give him a small little stick onto the dorsum, a little pinch. I have to make sure that I'm on bone, which I am. I start the injection very slowly. I watch the skin. I'm watching the product as well. And I'm going to keep my fingers here to prevent the product from spreading too much. And that's how I inject radixes of noses, okay, to eliminate a bump. I do this line on a male. I do this line on a female. I don't want to see a female with a nose starting up over here. I don't want to see a male with a nose starting up over here just because you're chasing out a bump. I'd rather leave a bit of a bump and not have a nose that looks like it's starting in the middle of the forehead. So you go from the tarsal fold on the male, you go from a lash line a little lower on a female, and that will tell you from that distance whether or not you can eliminate with one injection the bump that he had in his nose. It's gone. Okay? And I've used literally I don't know what he gave me. It's like 0.2 or 0.02 or 0.03. Yeah. So he gave me 0.2 and I'm down to 0.13. So I used 0.05, let's say. And what you do is you give it a little squeeze like this. And you tell them not to wear their sunglasses up there, to wear them down here for a day until the stuff integrates into the tissue. That little pressure that you put over here is your Da Vinci signature that you don't sign, but you leave your little fingerprint on it because, as Kent has shown us, this is a curve. This isn't Avatar. It's not 2 straight lines. This is a curve, and so you want to use the pulp of your index and your finger to create that curve and to maintain that curve. Okay? Bumpless. That's fine. You can actually leave a little bit of a bump on a male. It's not a terrible thing. Okay? I'm going to get to do his piriform, and then we're going to do the other side. If I wanted to inject his nose, he has a 90-degree takeoff, which is pretty good. I like his nose all around. Yeah, it's got a good nose. The way I inject the tip of the nose, and I won't do it on him, is to put my needle underneath the tip over here, lift the nose up like that, leave my needle there, and just let the nose fall right down on it. I do the same thing for chins. Lift the chin up, leave the needle there, let the chin fall onto the needle. They don't even know that it's happening because of the proprioception. It's the gate theory, right? So it works really well. Can I have the define on a same type of red needle, please? The same one that we had before.
You got it.
Sure. So for the depth of injection in chin, because we're not going to do it on him, but if I was injecting a male, and we just did this the other day, that's perfect. What I usually do in a guy like this who has a little bit of a crease over here is I use 2 injection points. And you can use those injection points from an approach like this, or you can use an point like this, because we want the chin, the width of the inside of the iris to iris. And what my nurse does is she holds the cap on the cleft. And I create a butt cheek, or a butt chin, I guess is what it's called. I basically inflate on both sides. It will soften, but it maintains the cleft. It doesn't allow the product to run into the cleft, and my injection depth is on bone. Okay? If it's a very thick chin, and then you have to remember that we're talking about height of chin as well. He's got great proportions down here, but if I had to lengthen him, I would lengthen him down this way as well, so my injection would definitely be from below. And then I withdraw a little bit and put some product down along over here, because you got to remember about height over here as well. So in the male projection, he's good. You want it to be at the level of the lips or head. And in a female, you want it to be at that level or slightly behind. I'm going to inject the piriform region now because I think...
You want to draw that piriform, kind of what you're trying to accomplish there?
Okay, so let's tilt him up. How you doing? You okay? I'll give you a break with some water in a second.
Sorry.
Good, Ryan, thanks. Lift your chin up here just a bit, buddy. I want to show you something, okay? We're looking at this area right over here, which is the piriform area, which you can't see on the AP view, but I can see hovering over the top of him. He has some full lips over there. But what I don't like about his piriform area here is that it's recessed, okay? And what I'd like to do is I want to see if I can just get rid of that little bit of excess that he has over here and possibly, look, just bring in the nostril just a little bit. I want to see if I can narrow him just a tad, okay? So what I'm going to do is I'm going to clean over here. I'm going to approach him a little bit from behind so you guys can see. What am I aiming for? Opposite commissure. Where's my injection depth, guys? Where am I going to be? Bone or skin? Right, but I want to get down onto piriform, right?
I'll watch closely because you'll get home and try to remember how you did this.
So you take the nose over to the side, and you're going to feel a small stick, and you flick it as you go in.
He won't like that.
Most patients don't like that, but he'll tell you that was about a 2 out of 10, not a 10 out of 10. And I got to make sure that I'm on bone. Look, can't go any deeper. I'm aiming for the opposite commissure. I'm away from the angular artery. I'm away from the facial artery that's up there. Okay? I start my injection slowly.
I often lift the nose at the same time.
Correct. We're going to take a little bit of a lift over here.
And then you have a space for it to reflate.
Here comes the slow injection. Very, very slow. And then what I do is exactly like Ken says, but I use my needle very often to do that, is I release about 1 millimeter off my bolus.
And you got a space to
lift.
fill.
See how I lift like that? And I put another little bolus. So what am I doing here? You'll hear people talk about the tower technique. I don't understand it, to be honest with you. Not that I have anything against it, but I just don't understand it. The tower technique, I just put in 0.2. And I got a beautiful little vessel there. I might have gone right through it, but that's okay. So, hold that. The tower technique is where you inject, and as you're injecting, you're withdrawing. That, to me, is like a soft whip ice cream. You know, you inject at the bottom, and as you release, you get that little whippy tail at the top. I don't understand how that supports anything, to be honest with you. If I wanted to have pillar support, I would rather think in terms of hard ice cream. Take your cone, put your first bowl of ice cream on the top of the cone, and the second bowl that you're putting is on top of that, partially sort of sitting in it. So when I make a little bolus over here, I make a bolus of 0.1, just like Kent was showing you. Elevate the nose with your little retractor or with my needle, and now I'm inside my previous bolus because I'm up by about 1 millimeter or so, and I put my second bolus right on top of it. That's how I'm thinking. And the idea being is to flatten out this area and perhaps, it's going to be a little difficult on him, but perhaps also narrow down a nostril that's a wide nostril. I do that very often on Afro-Americans that have wider nostrils, on Asians that have wider nostrils, especially if they've got retrograde or piriform protrusion.
Now you notice when he came out, he got a little bit inside his mouth because that's why he's puckering up, because you got a little taste in your mouth, right? Do you have a little taste?
Not really, huh?
No?
Sometimes if you aim down too low, you're going to start to inject into the gingiva, and the patient will say, what's that stuff on the inside of my mouth?
He's got a little xylocaine in his mouth.
Yeah, it sounds xylocaine. It's a little bit of hyaluronic acid. Tell them it's great.
Yeah, both.
Just
it's
coat it over your teeth. It's like getting
bits,
veneers.
Tiny bit.
Come up with any excuse. You okay?
Dr. Swift, which products would you use there besides the...
I was Define.
What other products would you use there?
You could use...
Define, Voluma. I even use Ultra Plus here because Ultra Plus is really very cohesive. I'll use Restylane Lift.
Restylane good.
Restylane Lift is a great
thing over there. Gotta have something that's got to lift because you want You're trying to get projection here. That's what you're trying to do. Get
I've even started to cant his nose a little bit to the left because of the lift over here. So we're going to have to do the other side, or we'll leave him. See?
You got a really nice lift there. Really good.
Yep. I'm sorry? I use Bellotero, but you guys don't have Bellotero except for Bellotero Balance. You have volume? Since when? Here in the U.S.?
No, we are in Argentina.
Oh, you're in Argentina. I'm sorry. Well, welcome. Welcome. Yes, I would use Bellotero volume over here, but they don't have it. I'm talking to, I thought, an American crowd. I apologize for that. Yes, it's a very good place to use that as well. Yeah.
Okay, so I'm a big aspirator. So I do your technique on bone, and I always aspirate.
Right.
Now that you've added your little tweak with kind of releasing off bone and coming up to do your next scoop of ice cream,
Right.
do you then, for those that aspirate?
You can. But you need 2 hands to aspirate. Don't aspirate. I see people doing aspiration when they're hovering with one. If you're touching bone and you want to aspirate, you can use your thumb to pull back on the syringe. But if you're actually in the subcutaneous tissue or into muscle or whatever you are that's above bone, you're going to have a tendency to, if you try to aspirate with one hand, that you'll move a little bit. You have to stabilize it with the other hand. Some people inject, like you'll see Maurizio, if you know Maurizio De Maio, he'll inject with his hand backwards like this because he likes to stabilize things and flick with his thumb as he's aspirating. So just get into the habit of making sure that the syringe doesn't move when you're aspirating, to be sure. What I'm doing over here is I'm putting a bolus in, which is, as Ken said, is filling the space. And then I'm putting my second injection. When I say lift, I'm lifting 1 millimeter. I'm putting that second injection inside my first bolus, so to speak. So I'm sort of scrunching the 2 ice cream balls, one on top of the other.
And the other reason he's twitching a little bit is because all these fillers have an anesthetic, and so you've numbed his right upper lip. Right, Ryan? Your right upper lip's numb?
Not even that bad.
Not even that bad.
Well,
but that's a great area to inject before you do lips also,
Yeah.
right? Right.
Yeah.
Okay. So I'm going to finish him off. Let's take some questions, and Kent will try to field them. What have I got here? Refine. Can I have refine on the BD, on their BD2 again?
We got a mic we can roll so everybody can hear him. Got
Oh, yeah,
a
you want me to
mic
use
there,
cannula
Bob?
inside?
I got a mic if somebody wants to run it.
Okay. Okay, Stan.
Can I have a 27 gauge cannula?
We'll have a mic, then everybody can hear the question.
Again, he's looking too good when he came in originally, so I don't have.
Yeah, he looked
1, 2.
terrible when he came in.
Yeah, I don't have a lot of work to do on him. But if he came in originally to my office, I would say because he's a guy.
27, how long? 27 what?
27 gauge.
Inch and a half?
Yeah, inch and a half.
Okay.
I have it over there. It's in my box.
What brand of cannulas do you like these days?
Oh, God. You're really trying to corner me on that, huh?
When you inject the nose, do you ever inject off the center to correct the curvature?
Can't see in this
So
light.
here we go. I'll answer both questions. First question is, do I prefer a specific type of cannula? I like ones that are a little less flexible, to be honest with
No,
you.
that's not it.
Magic needles, which are cannulas that come from Europe, aren't bad as well. There's TSKs, and there's the LN cannulas. To be honest with you, I use them all. So I'm quite comfortable with all of them, but I think if there's a lot of flexibility to a cannula, we prefer a little more stiff than flexible nowadays when you're trying to use a 25.
Flexible than the TSKs?
Right,
I mean, less flexible. than
correct.
TSKs.
Right. But whatever you're comfortable with. Some of them come with a previous trocar. What I do when I do cannula work, and I'm going to try to do that with him over here, is I use the same size trocar. Yeah, refine. I use the same size trocar as I do cannula size. That's just to challenge myself to see if I can find that hole at the same size. A lot of people, they use a 26 for a 27. They'll use a 23 for a 25. I like to keep it as painless as possible or pain-free as possible for the patient. My most embarrassing time up on the podium was when I was in Switzerland, in Bern, Switzerland, and they gave me a venue over there that was a movie house. It was a movie theater, so that the patient was being projected on a screen that was 30 feet high. His face was 30 feet high. I met the patient 2 minutes before I was actually injecting because I like to do it that way. They always say, can we send you pictures of what you're going to inject? And I say, don't. I don't hyper-select the patients in my practice. I don't go out on the street and say, yeah, you can be injected and you can't. I don't want to do that on the podium. I want to try to simulate as much as I can what goes on in my office. I'm going to meet them for the first time 2 minutes before. They said, great. So I go to meet this guy 2 minutes before. He's going to be on a 30-foot screen. He's got a face that looks like the surface of the moon because he's got acne scars everywhere, ice picks and craters and things that you couldn't believe all over his face. I said, you had acne when you were younger? He says, yeah. I said, are you taking any medication? He says, yeah. I said, what are you taking? He says, Coumadin. I said, really? I said, why are you on Coumadin? He says, because I had 3 pulmonary emboli in the past 6 months. I have a coagulation problem in my skin. The person who was from the company just about fainted and said, we'll find you somebody else. I said, no, don't worry. This is what would happen. The patient comes to see me in my office. Am I going to inject this patient? The answer is yes.
Yeah.
I would inject him. So I said, let's do it. So we put this patient down, and I said, why is your skin so thin? He says, because I dermal roller it every day. I said, oh, boy. I said, why is it so thick? He says, I dermal roller it. And I said, it's really thick. He said, yeah, I've had Sculptra in the past, too. I said, anything else you want to throw at me? So I said, we're going to do this. We'll do this. And what I do is I just adapt what I do in my office. And I explained his history. I came out and I introduced him exactly like I said, grandpa's. And I said, listen, this is a guy who's on blood thinners. He has very thick skin. He has the surface of the moon on his face. It's going to be a little more difficult. What am I going to do to try to limit the bleeding? I'm going to use the smallest needles possible that I can. So everything that you're going to give me is either going to be a 30 or a 27. I don't want to see anything bigger than that. I'm going to use cannulas as often as possible so I don't bruise him. So give me everything just about in cannulas. I'm going to have ice ready because I want to pre-ice him so that I can have the skin somewhat vasoconstricted when I inject. And I'm going to put pressure, so keep pads over here for me so that I can put pads on. And I started to inject this guy. So I go ahead and I put in a couple of injections. We're holding pressure. I'm talking like I'm doing now. His face is 30 feet high. And I say, and where they have me injecting is behind the screen, so I can't see the audience. Because there's no place in front of the screen in a movie theater for you to stand with a table like this. So I'm in the dark behind, and they gave me like a little light bulb or something. They were trying to kill me. Or him, or somebody. I don't know what they were doing. And so I go ahead and I stick my needle in. I twirl it to do the cannula, like we're going to do on him. I pull my needle out. Okay. My assistant was doing something else, so I didn't wait for her, which I should have. I went and I got my syringe with the cannula, and I come back, and for the first time in this guy's life, he didn't bleed. And I can't find the hole. Because his face is the surface of the moon. So I'm sitting here with my cannula hovering over his skin, slapping him, squeezing him, pinching him, trying to find the hole for the cannula, and I just can't find it. I can't see it. I'm half in the dark, and I can't see it, and my cannula is hovering. And that was when the most embarrassing time of my professional career happened to me on stage, because from the audience of 600 people, I heard, "A little up, to the left. No, a little more to the right." On a 30-foot screen, it looked like a manhole cover, and I couldn't find it.
Now,
that's a little anecdote.
As everyone's learned who's used cannulas, most of these cannulas, hub of the needle is oblong, so and the lure lock is round. So you have to prime them a little bit, be a little careful, otherwise you split them. These are actually, this one's made by Galderma, but it's actually the low bidder somewhere. So all these syringes are terrible. But anyway, you have to prime them as well, but you got to make sure you don't split the rim. So this is a 27 gauge, 1.5 inches, and you're going to use a 25 trocar, right?
Actually, the trocar, what did you give me?
25.
Oh, great. So you're going to try and make it easier for me. Might be, but I'll probably struggle anyways, because I just told you that story.
25 is about right.
How I find to use a cannula is holding it as a dart. It's the easiest way. I see a lot of people try to go ahead and they try to put the cannula in like this, and they start to hover. So what I do is I'll stretch the skin out. We probably laced up a vessel. Go ahead. I'll see if I can find a hole afterwards. I want to make sure they can see. A little drop of blood will help you, and then I'm going to be in on bone. Okay? Again, my little chlorhexidine pad, because I don't like to touch anything that goes into the skin. When we do liposuction, we never touch the part of the cannula that goes into the patient. I don't like to touch the part of the cannula that goes in. If I have to stem some bleeding, I make sure that I have a little bit of the eye-blinding stuff, the chlorhexidine, okay, to make sure that I don't do that. We're going to turn his head a little bit like this, okay? And this can feel a little bit unusual. So if he complains a little bit, I want to see pop. Did you almost hear that pop? That's me going through the Galea because I was able to do it, and then we can start the flow of product. I think I'm subgaleal.
Speed bump.
Yeah. Now, I was telling you before that in the situation that you are injecting with the needle, you might see, are you comfortable? You okay?
All right.
You're okay. It's not as comfortable as the other one, I bet. No. Okay. Because this is a little bit of an unusual sensation. Okay? You okay?
It's fine.
Fine. You're looking in the thing. Don't look. I'm going to just change the angle here a little bit, and I'm going to go up a little bit, and we're going to fill him just a bit over here. And we're going to take a look at something. Anti and retro.
Yeah.
Okay.
Sometimes the 27 gauge is a little bit too much like a noodle, so a 25 sometimes is a little bit better.
Sometimes when you go in with the needle, you'll see the product shoot up vertically. And you'll go, oh my God, I injected into a vessel. You haven't. If you take a look at the subfascial underneath the Galea, there's little septi that are attached down to the bone. And those little septi that are attached down to the bone are very easy to break, but they're there because your forehead shouldn't woggle from side to side. It's moving up and down. So there's little gutters and runners over there. You break through them very easily, but you can inject and the product can shoot up on one of those gutters and you'll think that you're inside a vessel. Don't worry about it. Just press on it. It'll shatter and break. So let's just take a look at a curiosity to see, was I really, I felt that I was subfascial. Can you hold this? Underneath the Galea. But I want to take a look and see if I was. Maybe I was lucky. can you raise your eyes for me, please? Raise your eyebrows. Yeah, eyebrows. Okay, so I was underneath because I don't see much of an effect. But I got to do something to get that eyebrow up to match the other side. So I'm going to dart away from this for a second, and we're going to get the, what did you give me? Give me the refined, but give it to me on a 30 gauge needle, please, in the regular syringe. Because I'm really going to give him a little bit of a boost here. When you want to contour a brow with filler, you can contour a brow this way, and you can contour a brow to give it a peak this way. Okay? You heard Ken talk about that. You can use a cannula and force the brow up to cause a peak, or you can inject onto the orbital rim over here and give the eyebrow what appears to be a peak because you create a little Fabergé egg underneath here. We don't want to peak him. We're going to try to do this. When patients come into my office and say to me, Dr. Swift, can you do this? And they pull like this. What do? I look at them like this and I say, am I doing it okay? They don't like my sense of humor. They say no on me. And I say, well, I can if I put in a little bit of volume into your temples. So we're going to see if we can get that eyebrow up.
This is essentially a 30 gauge.
29?
30.
Yeah, no problem.
30. Half
Can I have a little cleanser again, please? It's right here. I got it. There's a little pink stuff. Always have a little bit, not a lot, but just a little bit over there. I'm going to go, where am I going here, guys? So 1 centimeter up, and then over, this way. Okay, well, they're getting very feisty here. 1 centimeter up, 1 centimeter over. Look at that beautiful big vein. There's no pulsation in it. So I'm going to try to pick a spot that's just a little bit above it. I'm going to stretch. Okay, can you guys see this? I can't see the monitor. Yeah, I'm going to keep my hands out of the way for the monitor.
You got to go back just a little tiny bit. You're right on that vein.
Yeah, I know. I'm going to try to miss that thing. This is it right here, right, Kent?
You're
How about
right
there?
Right there.
Want me to go right here?
Yeah.
Okay, it's his fault. I'm just inside that vein. There goes my finger behind it.
And he's going to pull up the brow just a little bit. There you go. I like that.
And are you repositioning the needle when you do that?
I don't know.
Well, he's going to raise it above bone.
Oh, listen to this. It's the first time I've done it like this, so I don't know. No, it's okay. We're being fine. I'm injecting very slowly, but he wants me to reposition the tissue over that, which is kind of an interesting concept. I haven't done that, but I'm just injecting in the same place.
And pull the brow up.
Okay.
And pull the brow up.
Yeah, I'm pulling. Here, okay. I'll pull it here. How's that?
No.
Too much?
Here.
Go ahead. Okay. Got to make sure that I'm on the bone. Okay?
Yeah.
I'm injecting very slowly on bone. So you have your nurse do that? Is that what you do, Ken?
No, I do it.
Okay. Right. You have what on the other side? So they don't pull away. Right. Because you want to make sure. Do you think I was on bone here, guys? Look at my needle. I wasn't letting him get away from me.
He doesn't want to see that.
That's okay. I didn't want to let him get away from me. But I agree. What I do is I triangulate my hands so that I move with them if they have a tendency to move away. But that's a great idea. Thank you. I'll be sure to mention it next session and take credit for it. I'll give you props. I think that's a great idea, is to go ahead and have something so they can't push away, or you can have your nurse just gently, hold them.
The other thing with cannulas, especially with type 5, 6, I've seen at age a number of times, I always put a little deposit of a little product at the attic. It seems to decrease the friction.
At the
opening.
At the opening. You're talking just as soon as you enter in underneath the skin, you put a little bit of product, like a little anesthetic.
Pounding on bone.
Yeah, I find that the pain from cannulas comes from, I don't like to force cannulas where they don't want to go. I got into trouble with my kids that way because I never forced them to do things they didn't want to do. But with cannulas, I don't want to force the cannula where it doesn't want to go. I like it to find its happy place. And Kent has this little trick where he spins it, but when he's spinning it, he's not spinning it where it doesn't want to go. He's just giving it a little bit of an oomph right through the little septi to be able to penetrate. But when I put a cannula in, and we can do this cheek over here with a cannula, you're going to see that for me it has to glide most of the time. So I don't force it. When you run a cannula along the orbital rim or you run it on periosteum, patients do not like that, and they very often get a vasovagal from it too, especially men. So be prepared about that. There you go. Look into the camera. Almost. We got to get it up a little bit higher.
I gave you a new one. It's a new one. I've sharpened it.
Thank you. I'm going to do a little trick over here to see if I can kick up the tail. I'm going to go ahead and give him a little injection right over here, small injection, right on the bone. This is the way we used to do it back in 2001 when we presented the way to be able to. What you're doing over here, what you're trying to do is, if in the event that you have an eyebrow that's sitting above the promontory, if you go ahead and you put some product in on the promontory, it acts like a boat cutting through the water. And when it cuts through the water, it makes a wake on either side. So it pushes things that are on above it up. And so that way we can actually perhaps get a little more elevation on his eyebrow over here. Take a look.
Yeah.
Okay. Oh, straight up. Okay, we're still a little bit flatter, and we're going to adjust that in a second. So that's a great comment, though, but thank you very much for that, for the idea of putting a little teeny bit of product in underneath the skin when you start with the cannulas. I see a lot of people put actually local into the skin to be able to put the trocar in, but if you do the technique, can I have this on a same product? What is this?
That's Refine.
Refine, yeah. So let me have it on a 27 cannula. I'll do his cheek over here with the cannula just to show them the difference. Okay?
That one I just gave you.
So can I have a 27 gauge cannula and a 27 gauge needle? So we're going to be able to struggle here a little bit. But I'll show you how I avoid having to put local anesthetic into the skin. Where's my tackle box?
There.
Here it is. Oh, we can get all the stuff from here. Look at all these reds I have over here, too. I just came prepared.
So there's your 27 gauge.
Perfect. And I'll take a 27 gauge needle if you have one.
You want a 27 gauge needle?
Yep.
Okay, here you go.
Perfect. So you're going to hold this for me. We're going to do the cheek on this side over here. I'll use the cannula technique. So here's the needle. Okay. So what I do is I choose my area that I want to treat. I do it for comfort's sake. If I want to come from this angle or from this angle, as long as I'm coming lateral, I will go ahead and I will retract the skin and let it fall into the needle. And I don't have to use any anesthetic on the cheek in that situation. And then what you do is you dial in the combination for youth and attractiveness. See, it's 3 to the right, 2 to the left. We don't want to get too punchy now because it's been
So he's
my
going to
trusty
go
assistant
exactly
here.
the same angle as his trocar.
We're going to try to do the exact same angle, and I'm going to
Of
try.
course you are.
Go ahead. Yep. Sure. Go ahead. Now that thing has disappeared. We're going to wait for a little drop of blood. Be patient. What kind of cannula is this? I haven't seen one of these before.
27 gauge, inch and a half. Still can.
I like my shorter cannulas for this. I don't think I'm going to be able to get this in. Can I have the needle again, please? I don't want to hurt him. This is a fairly long one, but I don't usually use that. I use about one that's a little bit smaller. So we're going to try the same thing over here. Little stick, little windshield wiper action over here. I'm going to try to come in. Hang on a second. Take that out. We're going to stretch the skin, and there we go. Okay. So what I do is I just gently advance the cannula as it goes underneath the skin, and I let it find its happy place. If it doesn't want, I put a little bit of a deposit of product, just as you were talking about. I'll retract, and then I'll be able to get across over here. Certainly if I'm going into the anteromedial cheek, this is the approach that I want, and I want to be able to fill it up just a little bit like this, nice and slow. Okay? Beautiful. You're doing great. If you want to get down underneath orbicularis over here, you can push the cannula through. You'll feel a little pop, and where you'll be is you're going to be in the SOOF. Okay? Slow injection again. Anti and retrograde. Change your direction. Okay? You can do it like this. Not a bad cannula, but this is a little longer than what I usually use. But it's fine. Okay? This one's, I think, almost a 2-inch needle, isn't it? 1 3/4 or something like that. I don't know exactly what it is as far as cannula goes. I use one that's like 1 1/4 to 1 1/2. It's a little stiffer. This is a little bit more flexible.
You're probably using 30 millimeters.
I'm going to lift it up to show you that you can see the outline of the cannula very well. What I noticed on his side of the face over here is he seemed to have a cutoff area over here. It was a little squarish. I'm going to see if I can change the direction of the cannula, which sometimes is a little tricky, especially with one.
It's the sleep side.
Yeah. Wasn't it the other side that was the sleep side you were telling me before?
No, it's left side.
There we go. Okay, you good? Mm-hmm. Great. And then we'll inject nice and slow like this and give him a little bit of product over here. Then we're going to use... You'll find that the Refine and Define have more resistance when you're injecting then Restylane or Restylane Lift. Okay.
That's why I often use a 25 gauge, because they are a little, it slows you down.
That's what it's doing.
Which is nice. And of course, the longer the cannula, the harder the rheology is, it's harder to inject. So that's why
Let me have the Define on a needle so we can just finish them up over here. Let me just move along because I'd love to get to one more patient to do some stuff that I really want to show you. Thank you.
30 gauge, 29 gauge.
So a line drawn from here to the bottom of the tragus is this pattern right here. It's going to be on the inside part. Instead of in the middle, it's going to be on the inside part of the orbital rim. So I think I should be somewhere about over here with his, that's not a new needle, with his apex over here. So we're going to give him a little injection. We're going to lift and see if we can just give him a little bit more over here. Can I get a new needle, please? And I'm going to try to use what I have left there, 0.1 something. I'll use that for the piriform region. Let's see how we're doing now. Well, we're starting to get rid of that thing. He still has this thing here, right? He still looks a little bit flat here. I'm going to use the cannula afterwards to adjust that. And we're going to go this way. So this is about 0.1. I think I don't have enough to be able to do the piriform region.
We'll get you some more.
So I'll use it just where I am over here to try to see if I can fix this.
You want Define for his piriform, Vasa?
Yeah, give me Define on
the left because he needs more lift.
Correct. I used to, and I don't think there's anything wrong with it. We were discussing this before. I'm one of the guys that was around when it was Neufil back in Europe, and we were reconstituting it with 5 cc's. We then learned that we had to bring it up to 8 or 10, and now we're even using 20 in hands. That's perfectly fine. If you take a look at somebody like Becky Fitzgerald, or if you look at Danny Vlahar, they are really amazing at the way they're able to sculpt the face with that. I find that it's not painting with the brush the way that I like to paint, so I just, before I had...
Define.
Yeah, thank you. Before I had these HA fillers that are more robust, I was a big Sculptra user. Okay, and I was using Sculptra in the temple, I was using Sculptra on the cheeks, I was using Sculptra all over the place. Then when I started to get Voluma, which was the first one that started to come out with a real robust type of a lift, and I was using Perlane as well, I went away from it in temple, I went away from it in cheeks, and I ended up being that Sculptra was for this area over here where I had no support and I wanted to thicken the skin. Once I got the more cohesive products, we started with the Vicross, and now with Refine and Define, I use cannulas over there, and I'm able to achieve pretty much the same thing. So I just went away from using it. That's all. I just got happier with the fact that I have an eraser for the product. We're going to do that little flick thing, okay? Close your eyes. This is a fresh needle, I assume. I'm going to see if I can keep this away from you guys. So let's see if I can do it this way. Okay? 3, 2. Oh, that sleeve's not working very well. I see it very well, but you guys can't. Okay, so I'll stay below him because of... No, I can't do it that way too. Let's see if we do him this way. That's good. Okay, I'll get up on one leg here and I'll climb up over. Here we go. You ready? 3, 2, 1, pop. Okay? I got to make sure that I'm on bone again. I'm going to turn him back to me. I'm aiming for the opposite commissure. I'm injecting down. Look at the angle. I'm away from the arteries. I'm away from the issues. I'm injecting very slowly. Watch the plunger. You probably won't see much of the plunger appear. Very slow injection. He's going to lift the nose, and then I'm going to come up just into my previous bolus, and I'm going to continue the injection. I'm prepared if I did skewer a vessel, then I'm prepared for it. I'm giving him just a little bit more over here. People are worried about vascular compression over here. He's doing great. People are worried about vascular compression over here, but I got to tell you that the chances of vascular compression, I just never seen it, and nobody has ever been able to demonstrate it. Okay? And then we just put a little pressure. How you doing?
Ken, when you're doing cheeks, when do you like to use a needle and when do you like to use a cannula?
Kent, the question is, when do you prefer to use the needle and when do you prefer to use the cannula in cheeks?
In cheeks? I use the needle vertical like he's done here, but I use the medial face, I use cannulas. Because you don't require much lift, and it's kind of a no-fly zone for me. So in this zone, in the medial cheeks, I use a cannula.
Me too. I'm anteromedial cannula only. I use cannula and needle in the lateral cheek, and if it's a real volume deficit, I'm doing one of two things. I'm either going to fat in which case I'm going to flood the face with fat, so I'll use maybe 15 cc's of fat to do it. Or if I decide that I want to do structure, I'll use a needle in 2 or 3 little pillars. Then I take the cannula out and I cover over the top like a canopy, like we discussed. We've done that together, Don. You've seen that. And then you save on a lot of product that way so that you don't end up causing a problem. Well, there we go. He's doing great.
Now, what would you think about doing his nasolabial fold on this side
Right.
with the cannula just to lift it up a bit?
Sure. The question to you, Kent, because you use cannulas on the piriform. When I first started doing piriforms, I was coming across like this. That's the way that Maurizio showed me how to do it. And then I got the idea of just going ahead and putting a bolus down, understanding that I had to stay on bone. But Kent uses the cannula quite a bit over here.
Yeah.
I'll show you. Can I have the refine
Want a 27 gauge
on
again?
a 27? Yeah, but not
Maybe
as
we'll
long.
use a
Maybe
shorter
a shorter one. I have a shorter one right here.
Oh, here.
I move them, not recumbent. I mean, this is what we're working with over here, but my patients are usually sitting a little bit higher, and I very often sit them up, and before I finish, I make sure that they get completely
how
up
much have you got
and turn
there? Yeah,
towards
we need a
me,
fresh
and they're
refine.
sitting this way, so that I can see what the story is. But, I mean, it's 6 of one, half a dozen the other. When I first started injecting toxin in 1992, we didn't have a clue of what we were doing, and nobody could tell me how to basically inject Botox at the time, which is all we had. And so I was a surgeon. I'm used to operating sitting down. I had the patients lying flat, and I would sit at the head of the bed, and I would inject retrograde. I would hold the needle back like this, and I would inject with them lying flat, because that's the way I did blepharoplasties. I figured that's the way you do stuff like that. And it wasn't for about 4 or 5 years until I finally started to sit the patients up, because people were saying, don't let them lie flat after you inject them. And I was injecting them lying flat in the first place. So, and did it make a difference? I had 1 case of partial ptosis in 7 or 8 years, and that was in a patient that I specifically was targeting one of those little crunch lines that they made with the orbicularis, and I told her it would happen, and she still wanted me to try. And I ended up giving her about 1.5 millimeters ptosis on that side.
27 gauge and a 27 gauge trocar.
Okay, we can hold that. So I'm going to try to find this over here. So
I like the 25 gauge myself, but it's a little bit 6s.
now we're going to see if we can find this little hole again over here. Go ahead. I won't let you guys see it because I'm going to concentrate on finding the hole, which is a lot easier with this cannula. You
See how he
that?
drops his hand right down parallel?
Yeah, we
drop
do
it
this
down.
when we're doing folds. We do this when we're doing this area over here that you're going to see what we're going to do hopefully on the next patient. We'll take a little break and then I'll try to do the next patient half the face and I'll continue off camera for the other half. And what I'm doing now is I'm just trying to let the cannula, and Kent says we should spin it a little bit, but I'm trying to let the cannula find its happy place. You can see it. I'm probably about 1 millimeter underneath the dermis at the most, okay? This is a 27 and the product that they gave me is Refine. Yeah, it's Restylane Refine. We're doing Restylane.
27 gauge, 37 millimeters, so essentially 1.5 inches.
We're lifting, and we're trying to... Most of the time I'll show you, this is Kent's technique, which I'm trying to duplicate over here. Anything particularly you'd like me to do here, Kent?
No.
I'm doing okay?
Just break it up and break that septi up.
Yeah, that's what I'm doing.
There you go. Now we're talking.
We're talking now?
We're talking.
I guess we weren't talking before.
So you don't find less bruising if you do a little lighter with that bead bleb before you put the trocar in?
Haven't had that issue. But if you find if it's a patient maybe that is on blood thinners, then I don't worry about aspirin, I don't worry about Coumadin, I worry about the homeopathy. Patients on omega-3 are the ones that I end up always bruising.
Yeah.
Can I have a little BD2 with
Omega-3 is a big
do we got
sleeper.
here?
It's worse than aspirin.
BD2
with silk?
Oh, BD2 is silk.
Yeah. Because what I'm going to do is we've lifted up.
minis
He's
on
almost
these?
lost that nasolabial fold on that side too now. We're doing very well. But he has this crease at the
You want this
bottom.
one?
No, he wants the BD2.
We used to inject all the nasolabial folds in
So
that direction.
We'll put it in this.
That's the way Kent does it
touch?
with the cannula, but we used to do that with needles, and I always found that
that
patients
one
would come
has
with either a
better
blue
fold.
streak on the inside of the
Well,
nasolabial
that-
fold,
that's what he
or
wants.
with something that looked like a stick under the skin. It never made sense to me to inject the nasolabial fold in the dermis this way. Just didn't make sense. It's like walking along the street and you have an excavation and they're going to put the planks this way. There's no support there. You're going to fall in with the plank. So if you want to go across something, you want to bridge it, this is the way that I get rid of these little areas that are a little more stubborn, like in him over here. So I'll take that little silk, if you have it, on a little bit of a BD2. And what I do is I cross-hatch it. I bridge it. We talked about bridging, Kent and I, a while back, where you actually, it's not like the ferning that we heard about afterwards. It's a little different.
Touch, like it flows better with silk.
He's giving me all this new stuff. We're having a great time here. Okay.
So if you're using silk, use an easy touch instead of a BD2. With a BD2, it flows like water. You have no proprioception. So it's an easy touch. It looks the same, but it's got a different rheology. So then you can feel it. Otherwise, it's hard with the BD2s. You can't feel it as well. So that's nice feel, right?
Not bad. Here's my suggestion to you. I'm just using this Easy Touch for the first time, and it's really very, very slick, and everything is good. What I do is I retract the skin. I let it fall back into the needle, and I inject. Now look where I'm injecting with. If you can pan out with the camera just slightly. Thank you. Look where the plunger is. It's at the base of my thumb. So this is the last little point that I'll give you with him as we're slowly getting off here, is the fact that when you want to control flow, you have to get it down into a smaller needle. There's no question about that. Last little bit here, buddy. I'm really working from a funny angle, but I'm just going to get you here with little injections. There we go. I'm going to ask you to hold this for a second before we finish with you. There we go. Yes. So if I wanted to walk across from here to here, and there's that valley or that chasm in between, we're going to put a plank across it where it has support on both sides. If you go ahead and you put the plank this way, even though it's in soft tissue or it's sitting in sand, it doesn't have the stability. It needs a little bit of stability on both sides, so that I cross-hatch across the whole thing. And you'll notice that I drop the syringe into my palm. So I'm going to give you a little last story over here before we move on to the next patient. We'll finish exactly at 4:30 with him. We've just about obliterated the nasolabial fold on that side now, which is good. Okay, so what the story is as follows. When I was engaged, it's always the story about my wife. When I was engaged to my wife, I took her to a carnival to try to win her one of these big stuffed animals, right? And I really wanted to win that stuffed animal, so I'm not very good at most things, but I figured, hey, I can hit the star on, or knock out the star on one of those rifle things, because I had the rifle over here and the star was just about over there. I said, come on, this is too easy. It's so close. The guy said, go ahead, pay your $2. I think it was $3 at the time, or $2, whatever. So I paid him $2 and I said, wow, I'm going to win this big teddy bear. And I took out this air rifle, which was a CO2 rifle, and I lined it up, and I went ahead, pulled the trigger, and 100 pellets came out like this. And I said, oh, I understand what these guys do. They always have an edge. They cranked up the pressure on the gun so high that you just pull the trigger and they came out like buckshot. Okay, I said, I know how to do this. Okay, we're now $30 into it, about 15. And my wife is tugging at me to go on one of the rides, and I'm saying, I'm going to win you that damn teddy bear if it kills me. And the guy looks at me and he says to me, buddy, you need some help here. Now, this is the Carney, right? This is the Carney. So I said, yeah, I could use some help. Now, I'm looking at this guy, okay? I figured grade 5 education, gray hair and a ponytail. It's about the only thing I was jealous of, gray hair and a ponytail. One tooth, wife beater on, pockmarked skin, pants down to here. And he looks at me, and he's literally just about slapped me across the face, because he said, you know what the problem is? And I said, well, what is it? He said, you're using the big muscles of your forearm instead of the small muscles of your hand. And I was a plastic surgery resident at that time under this guy right here.
Just clean it off.
You never told me that. Don. Okay. And I said, what? He said, you know, you're using the big muscles instead of the small muscles of your hand when you're a sharpshooter in the Army. And now I understood where this guy was coming from, because he had done Army time. He said, they don't tell you to pull the trigger. What do they tell you to do? Squeeze. Squeeze the trigger. And he was so right, because if you use the long tendons of your hand, you're using the big muscles in your forearm that come to the long tendons, which is the tendon for the thumb and the flexor tendons for the fingers. It's a pulley system, and because of the mechanics of the pulley system, a little contraction here ends up with a much bigger movement over here. But if you're using the small muscles of your hand, which are bone to bone, a little squeeze gives you a little bit of pressure. He said, put your finger on the trigger. Don't pull it. Just squeeze your palm. He was telling me to squeeze my thenar eminence. And I took the gun and I aimed it and I just squeezed my palm, and one pellet came out. That's it. That's how light the pressure was on it. And I just went ahead. It took me 2 tries, and I just went right around this little. It was so close. It was easy. And I won her that thing, which I was very proud of, and she kept for 2 days and threw in the garbage. But that's not the point. The point is you can learn from everybody something. And when I started to inject, it came back into my mind, that story, because when I wanted to be able to control small amounts of product in the tear trough, in the forehead, if I'm going to try to control small amounts of product into a nasolabial fold where I'm injecting superficially, I cannot do it with my thumb. But if you put the plunger down into your palm, you can hang a drop off the tip of the needle and let the drop get bigger and bigger of water, which has no cohesivity, and you can do that. So the amount of control that you have on your squeezing is way over the control that you have on the pulling. So I suggest to you, especially women who have smaller hands, that if you want to get better control, don't be afraid to decant the product into a BD2, which we can show you how to do, or into another syringe so that you can get the plunger into your palm and you'll be a much better fine injector. Okay? That's how it works. How are we doing? Oh my God.
I think he's got this little zone here.
Okay.
He just needs...
Yeah, a little flatness over there, and that's what I was talking about before. So what should we do that with? We'll do with a little cannula or something?
Yeah.
Okay. We'll finish that up with a cannula. But his nasolabial folds are looking very good. His eyebrows are looking just about the same that he was before. He's got his nice square face. If I wanted to augment his jawline, guys, think about this. If I want to do a jawline on a guy that doesn't have a very good jawline, if you wanted to go after me on a jawline, feel for the gonial angle like this. Take your needle. Go in vertical, and you must touch bone. If you don't feel bone, you don't inject. You stay on bone. Use a high G prime product. You can use Voluma. You can use the Define if you want. You can use Bellaterra Volume if you like, ladies. Okay.
So you need to take it out.
That's right. And you put in a bolus here of about 1/4 cc. And that will cause the angle over here. If you're missing an angle on a male or a female, it's not a masseter, it's a parotid. Be careful about that, because I don't like to violate the parotid very much if I can avoid it. Okay? If you want to do the jawline, which I was doing on men the other day, okay, what you do is where I put my access for my cannula is right over the artery. Okay, so what you do is you have him clench his teeth. Give me a good clench there, Ryan. Thanks, buddy. There, look at that beautiful masseter. Here's his artery right here. I put in my little needle stick, and then I put my cannula in, and I start to advance it this way. I'm moving away from danger, because I'm standing over the artery, moving away from it. I can't hit it. And if I move this way, I'm moving away from the artery again. If I start back here, even though it's more comfortable for me, I can dive down deep and catch that artery. That'll cause a major bruise. And if you dwell in it and inject, it'll cause a major problem. We don't want that. So that's where I do my cannula work for over here. What we'll see, if we have time to do the next patient now, or we'll do her tomorrow morning, is I have a technique now that I've changed away from cannula in doing contouring of the face in females or males that have jowls. Where did I tell you the jowl is coming from? Here? Where? Here. You'll see me flick the skin, and I'll do this, and I'll inject, and do that with about 0.05, not 0.1, but 0.05 of product. I'll do that, and I'll put in 0.4. So I'll put in a series of little injections, literally to glue them up like this. There's some sort of integration that's happening with the product now, and because of the small ligaments that are sitting over the parotid, it's almost as if you can ratchet them up like this. And I'll set the patient up tomorrow, and hopefully we'll see the difference in a contour of a jawline, that you're going to actually be able to take up the slack on a lot of that jowl that you get. Now, you get that jowl when you treat masseters in patients over 45. You're taking down their volume over here. And once you take down the volume, the skin will slide forward and you'll get a little jowling because of that mandibular ligament that's holding things over here. In those situations, I can't build back up over here because that's where I took the volume down to narrow the face. So I build over here in the preauricular area. And we take up the slack of this from the gutter that's just above it like that. So let me just treat this last little bit over here. What have you got? Some cleanser, please? Okay. Thank you. Kent, go ahead and make whatever comments or take whatever questions you like. I'm just going to go ahead. I'm trying to keep my hands out of the way, so we're going to let him just a little stick, a little twirl.
A question. When you were injecting Dr. Swift in the anteromedial
Here you go.
side of his left cheek with the cannula,
Right.
you didn't mark out the infraorbital foramen, but it seemed like you were passing over it.
Yes, I could
That's
pass
fine.
over it.
That's fine.
Sorry, buddy. This is going to be a little sensitive.
No,
A compression.
Nope.
no.
The only time you can get into a compression issue is if you're actually inside the foramen, and that we've seen
Can't
with
compress
injections
it
that
like
go
that.
up this way.
No, not an issue.
For those of you who like to practice your putting, if you're golfers and you put that little cup over there and you try to putt into the cup, they have these little machines that return the ball back to you. They're shaped like a V. So if you get it anywhere close, it sort of funnels into the hole and then the thing pops back out at you again. That's exactly what you're dealing with over here. It's shaped like an upside down V. And if you go ahead, the way you take a look at the contour, if you're injecting like this, it will guide your cannula into the foramen. So please don't inject in this direction if you can avoid it. How you doing, Ryan? No, you can do it with a needle. Whatever I said, whatever you feel fine. It's just the chances of bruising are going to be less. And it depends on whether I like the patient or not. If I don't like the patient, I'll go ahead and use something that's a little more noxious. He's being very good about this because this little stuff that we're doing over here, especially in him, that he doesn't have
It's
much.
just kind of annoying.
Yeah. It's a funny feeling. You just got to concentrate on your breathing and forget about the fact that I'm popping through. You see those little septi? Those are the septi that Rorik and Pessa told us about that separate the superficial fat pads. And then I'll cant sometimes and put a little bend on my cannula just because his seat is very high here. And I want to make it a little more comfortable. You know, in the old days, when we started with products like this,
Gel.
in the old days when we started with products like this, they were very thick. And we couldn't get them through regular cannulas. When I started the Restylane Sub-Q study, which was a product that, I don't know if you guys ever got it, but the Restylane Sub-Q, the particles were so big we had to inject it through a 14-gauge cannula.
Yeah, 14, 16
14,
gauge
16.
cannulas.
And you couldn't put it on the skin. You had to make your trocar hole in the hairline so you didn't leave a biopsy mark like from a trephine on the face. But now with these smaller flexible cannulas, somewhat flexible cannulas, that we're talking about 27s and 25s, you can place your injection port anywhere you like. Just be careful in people of color because you can leave a little hyperpigmented dot there afterwards, right? So we're going to run
I like
this back.
bioalchemid.
Is that the question? Oh, my God.
No, that's not a question. It's like the
Like
cannulas
bio,
we
yeah.
use for that.
Yeah.
That's good. I can be your masseuse.
Yes, you could. So the story here is, and what I do quite often sometimes, I'll see if I can do it now. Let's see how strong Lorraine is. Oh, she's a good girl. She didn't put it on too tight.
I put it on.
Oh, that's why. I'll sit the patient up. Okay? And I'll take a look at the contour and see that I still need, on the monitor,
right
a little bit up over here towards. My cannula is still in there, so I can redo it. And I do that always when I'm doing not upper lids, infrabrows, which we'll hopefully do also later.
Brow hollowing. A-frame has been erased from the dictionary.
You good, buddy? Mm-hmm. Sorry about that. Mm-hmm. So this is an area that you got to go gently because of the fact that there's a gazillion veins over here, and if you bruise somebody over here, that bruise will last for a good 10 days. Okay, it's all massage time because I left them lots of little bumps that you can have fun with.
So lips you blend, noses you mold, foreheads and this lateral cheek you massage.
He has been unbelievable.
Hey,
He really has. I got to tell you, the worst part of this is the butt. They sit there for an hour and a half on their butt, and it falls asleep. He doesn't feel it anymore.
I come from Calgary.
I won't even suggest that somebody massage it. But
4x4.
you're doing great. You did really, really well, Ryan, and thank you for coming by. I really appreciate it.
It's a pleasure.
Okay. Kent is just doing the molding. Yeah, go ahead, please.
On the cannula side, it seems like you use
touch it. Just don't play
Bingo.
with them.
It's not always the case. It depends on really the deformity of what you're dealing with. But I always find that in him, I did it purely all cannula on him, except for the one point that we were trying to emphasize, which was the light reflex point. But normally what I would have done on him, look how beautiful it is. I mean, here we have as much product as we need in order to create the results. So I was doing it because somebody asked and said, can we use cannula on one side and needle on the other? So I wanted to show you the difference. But I find typically cannula requires a little more than, except over here, cannula requires a little more than pillars. So you can flood the room, or you can build the pillars to support the ceiling, either one. So I usually, if I have a very deflated cheek, if you were to do my cheeks, I would ask you to do 1, 2, or 3 injections over here. And then I would ask you to coat over the top with a little bit of cannula so it creates structure. We don't really volumize. What we do is we project. We're pushing the cheek forward. Can we lift? I'm not sure we actually get lift. We get a vector that because we're pushing forward, we actually lift up a little bit. But I can't believe that you can lift the corner of a mouth, just by doing that.
The other thing that's interesting about refine and define is after you've blended them, molded them a little bit, do something else, come back a little bit, they seem to seek their own level. You notice that, Arthur? They seem to just kind of...
They're very moldable.
They're just
very moldable.
Flexible, and they don't need a lot of playing with them.
Ryan, thanks a ton, buddy. You were very good.